Eleanor had always prided herself on her sharp mind and quick wit, having worked as a mathematics professor for over 30 years before retirement. However, at 72, she began experiencing episodes that left her family deeply concerned. Following a minor stroke that initially seemed to have minimal lasting effects, Eleanor's daughter noticed subtle but persistent changes in her mother's cognitive abilities. Simple calculations that had once been effortless now required significant concentration, and Eleanor struggled to follow complex conversations or remember recent events. More troubling were the sudden moments of confusion and disorientation that seemed to come and go without warning. After several medical evaluations and comprehensive neuropsychological testing, Eleanor received a diagnosis that would reshape her family's understanding of cognitive decline: vascular neurocognitive disorder. Vascular neurocognitive disorder represents the second most common cause of dementia worldwide, affecting millions of individuals whose cognitive decline results from reduced blood flow to the brain rather than the protein deposits characteristic of Alzheimer's disease. This condition encompasses a broad spectrum of cognitive impairments caused by cerebrovascular disease, including both large vessel strokes and small vessel disease that may occur silently over many years. Unlike other forms of dementia that follow a gradual, progressive decline, vascular neurocognitive disorder often presents with a distinctive stepwise pattern of deterioration, where periods of relative stability are punctuated by sudden declines following vascular events. This unique presentation pattern reflects the underlying pathophysiology, where discrete episodes of brain tissue damage accumulate over time, creating a complex mosaic of preserved and impaired cognitive functions. The pathological mechanisms underlying vascular neurocognitive disorder involve multiple processes that compromise the brain's blood supply and oxygen delivery. Large vessel strokes, caused by blockages or hemorrhages in major cerebral arteries, can produce sudden and dramatic cognitive changes by damaging specific brain regions responsible for memory, language, executive function, or other cognitive domains. However, many cases of vascular neurocognitive disorder result from small vessel disease, a more insidious process where tiny arteries and capillaries throughout the brain become damaged by chronic conditions such as hypertension, diabetes, and atherosclerosis. These microscopic vascular changes may produce no obvious symptoms initially, but their cumulative effect over years or decades can result in significant cognitive impairment through a process sometimes referred to as silent strokes or cerebral small vessel disease. The clinical presentation of vascular neurocognitive disorder varies considerably depending on the location, size, and number of vascular lesions affecting the brain. Unlike Alzheimer's disease, which typically begins with memory problems, vascular neurocognitive disorder may initially present with executive dysfunction, including difficulties with planning, problem-solving, attention, and mental flexibility. Patients might struggle with tasks that require switching between different concepts or adapting to new situations, while their memory for personal events and general knowledge may remain relatively preserved. This pattern reflects the tendency for vascular lesions to affect frontal subcortical circuits that are particularly vulnerable to changes in blood flow and oxygen delivery. Language difficulties in vascular neurocognitive disorder can be particularly complex, often reflecting the specific vascular territories affected by stroke or chronic ischemia. Some patients may develop aphasia following strokes affecting language-dominant brain regions, while others might experience more subtle difficulties with word finding, verbal fluency, or comprehension of complex grammatical structures. Processing speed frequently becomes significantly impaired, with patients requiring much longer periods to complete cognitive tasks that were previously automatic. This slowing of mental processing can be particularly frustrating for individuals who were previously high-functioning, as they retain insight into their declining abilities while struggling to perform at their previous levels. Motor and sensory symptoms often accompany the cognitive changes in vascular neurocognitive disorder, providing important clues to the underlying vascular etiology. Patients may develop weakness, numbness, or coordination problems affecting one side of the body following strokes, or they might experience more subtle changes in gait, balance, and fine motor control related to small vessel disease. These physical symptoms can significantly impact daily functioning and independence, particularly when combined with cognitive impairments that affect judgment and safety awareness. Falls become a significant concern, as the combination of motor difficulties, cognitive impairment, and potentially impaired insight creates a dangerous constellation of risk factors. Emotional and behavioral changes frequently occur in vascular neurocognitive disorder, often reflecting damage to brain circuits involved in mood regulation and behavioral control. Depression affects a substantial proportion of patients, particularly following obvious strokes, and may significantly impact recovery and rehabilitation efforts. Some individuals develop emotional lability, experiencing sudden episodes of crying or laughter that seem disproportionate to the situation and difficult to control. Apathy, characterized by reduced motivation and initiative, can be particularly problematic as it interferes with participation in rehabilitation activities and social engagement that are crucial for maintaining cognitive function and quality of life. The diagnosis of vascular neurocognitive disorder requires careful evaluation by healthcare professionals familiar with cerebrovascular disease and its cognitive consequences. Unlike some other forms of dementia, vascular neurocognitive disorder often provides clear evidence of its underlying cause through brain imaging studies. Computed tomography or magnetic resonance imaging typically reveals evidence of strokes, white matter changes, or other vascular lesions that correlate with the patient's cognitive symptoms. The temporal relationship between vascular events and cognitive decline provides crucial diagnostic information, particularly when cognitive changes occur in clear temporal proximity to identified strokes or periods of cardiovascular instability. Neuropsychological testing plays a vital role in characterizing the specific pattern of cognitive strengths and weaknesses in vascular neurocognitive disorder. Unlike the relatively uniform global decline seen in advanced Alzheimer's disease, vascular neurocognitive disorder often produces a more variable cognitive profile, with some abilities remaining well-preserved while others are significantly impaired. This heterogeneous pattern reflects the patchy distribution of vascular lesions throughout the brain and can provide valuable information for treatment planning and rehabilitation efforts. Risk factor management represents the cornerstone of both prevention and treatment for vascular neurocognitive disorder. Controlling hypertension, diabetes, hyperlipidemia, and other cardiovascular risk factors can significantly reduce the risk of additional vascular events and may slow the progression of cognitive decline. Antiplatelet therapy, anticoagulation when appropriate, and aggressive management of atrial fibrillation and other sources of embolic stroke become crucial components of comprehensive care. Lifestyle modifications, including regular exercise, smoking cessation, and dietary changes, not only reduce vascular risk, but may also promote neuroplasticity and cognitive resilience. Rehabilitation approaches for vascular neurocognitive disorder often differ from those used in other forms of dementia, as the focal nature of many vascular lesions may allow for more targeted interventions. Cognitive rehabilitation strategies can help patients develop compensatory techniques for specific impairments, while physical and occupational therapy address motor and functional limitations. Speech therapy becomes particularly important for individuals with language impairments or swallowing difficulties following strokes. The prognosis for vascular neurocognitive disorder varies widely depending on the underlying vascular pathology, the extent of brain damage, and the success of risk factor modification. Some patients experience relatively stable cognitive function for extended periods when vascular risk factors are well controlled, while others may continue to decline due to ongoing small vessel disease or recurrent vascular events. Early recognition and aggressive treatment of vascular risk factors offer the best hope for preserving cognitive function and maintaining quality of life for individuals affected by this complex and heterogeneous condition.